All right, let's get right into it. We're tackling a topic that is, well, it's about as foundational as it gets for surgical practice and definitely high yield for anyone prepping for boards.
That's right. Clinical wound dressings and, of course, negative pressure wound therapy, NPWT.
This is where theory really hits the clinic floor.
Exactly. And our mission today is to, cut through all the noise. We want to give you a really concentrated review,
The core principles.
the core principles, the classifications, and the key things you need to know for choosing one product over another. We're going to move fast, but we're going for depth.
Okay, so let's start with a big picture concept that I think gets lost sometimes with all the marketing. What is the main principle we should remember when we're comparing all these modern dressings? Is there really a clear winner?
That is the perfect place to start. The honest, evidence-based principle is that there's very little concrete evidence that any one modern dressing is, fundamentally better than another.
So it's not about best, it's about best for this specific situation.
Precisely. The choice almost always comes down to the wound phase, the amount of exudate, where it is, and frankly, the cost.
It reframes the whole thing. So if we were to design that perfect theoretical dressing, what are the characteristics texts say it should have? The 9 points for the ideal dressing.
Right, the benchmark. You have to know these 9 points. The first couple are just about protection and safety.
The obvious stuff.
The obvious stuff. 1, it has to protect the wound physically and microbiologically. A real barrier.
And 2.
It has to be non-toxic and non-allergenic, of course.
Okay, so after protection, we get into the active management, the microenvironment. This is where it gets clever.
This is it. It's all about balance. Number 3, it has to maintain high wound humidity, which cells love, while, and this is key, removing excess exudate.
To avoid maceration.
Exactly. Number 4, it needs to allow for gaseous exchange. Oxygen in, CO2 out. 5, it should help remove necrotic material, usually by helping with autolysis.
And then promoting healing.
That's 6 and 7. It must promote epithelialization, and it must promote good, healthy granulation tissue.
So we protect, we manage the environment, and then what's left is the practical side of things.
Right, the logistics.
Yeah.
Number 8, it has to be atraumatic on application and probably more importantly on removal.
Huge for the patient.
Huge. And finally, number 9, it should be inexpensive and have a long shelf life. That list basically explains why we have so many different types of dressings.
Let's use that framework then and dive into the classifications, starting simple. Low adherent dressings, the workhorses. How do they work, and what are the 3 subtypes we need to recognize?
The low adherent dressings are pretty passive. Their main job is just to let exudate pass through into a secondary dressing without sticking to the wound itself.
So they're a contact layer.
Just a contact layer. And you see 3 main groups. First, you have tools. These are just open weave cloths soaked in paraffin like Gelane. Sometimes they have an antiseptic like the chlorhexidine in Back to Grass. Second, you've got textiles. These are just non-adhesive layers. Things like Utramen, Na Ultra, Mapitel.
And the third type?
Perforated multi-layered plastic films. Think Telfe or Meluno. They all do the same basic job.
Got it. Now let's contrast 2 that can sometimes cause confusion. Semi-permeable films and hydrogels. What's the key property of the films?
Semi-permeable films are all about selective permeability. They're these thin polyurethane sheets that let gases and water vapor out so the wound can breathe.
But they don't let other things in.
Correct. They are completely impermeable to liquids and bacteria. That's their main barrier function. You see non-adhesive ones like Omoderm or the really common adhesive ones like Opsite and Tegaderm.
Those are great because you can actually see the wound through them.
A huge clinical advantage. But then you have hydrogels, which are on the complete opposite end of the spectrum. They're all about donating moisture.
Right, they're giving water to the wound.
Exactly. They're made of insoluble polymers in up to 96% water. They just donate that water, keep things moist, and that really helps with autolytic debridement.
Okay, so where is the absolute critical contraindication for hydrogels? One thing you have to know for an exam.
This is a classic. Hydrogels are never, ever used on dry gangrene.
Why is that?
Gangrenous tissue, unless it's clearly infected, you want to keep it dry to reduce the risk of a secondary infection taking hold. So if you see gangrene, you're thinking dry dressing, not a moisture-donating gel.
Yeah, examples would be?
Things like Aquaform, Intrasite, or Granugel.
Okay, that makes sense. Keep the dry things dry. Now let's move to hydrocolloids and alginates. They both manage moisture, but in very different ways. What's the mechanism for each?
So hydrocolloids like Granuflex or Duoderm have things like sodium carboxymethylcellulose and gelatin, When that hits wound exudate, it absorbs it and forms this cohesive gel right on the wound surface.
Creating a sealed, moist environment.
A perfect, sealed, insulated environment. And you also have the newer hydrofiber dressings. Aquacel is the big one, where these dry fibers just instantly turn into a soft gel sheet on contact.
And the alginates. I always think of seaweed.
You should. That's where they come from. Brown seaweed. They are incredibly absorbent, and they also turn gelatinous. The unique thing is some contain calcium, which can help activate the clotting cascade.
So they're good for a wound that's oozing a bit?
A little bit, yes. But here's the main risk, the primary clinical issue with alginates. They have a real tendency to adhere to wounds that aren't producing a lot of exudate.
And that means pain on removal.
Significant pain and trauma when you take them off, so you really reserve them for heavily exudating wounds. Common names are sorbicin and cultistati.
Okay, last one in this section. Synthetic foams. What are they for?
Foams are usually polyurethane or silicone. Their real strength is in deep wounds. They can conform to a cavity, fill it up, and really obliterate that dead space.
So they're for managing depth and a lot of fluid.
Exactly. Because of their structure, they have a massive capacity for fluid. So they are specifically designed for heavily exudating wounds. You'll see names like Liafoam, Alevine, or Cavicare.
All right, let's shift gears to the big one. Negative pressure wound therapy, NPWT. This was a complete game changer. But let's start with the hard evidence. What's the recognized evidence gap here?
This is a critical point, especially for exams. Despite all the success stories we see, the official line is that there are currently no randomized controlled trials, no RCTs, to definitively prove that just applying suction improves overall wound healing rates.
That's actually surprising, isn't it, given how ubiquitous it is?
It is. It's an acknowledged evidence gap. We know it works clinically, but that gold standard proof isn't there yet.
So without that definitive RCT, what are the proposed mechanisms? Why do we think it works so well?
There are 5 main theories that are generally accepted. First, there's the direct suction effect, just physically pulling the wound edges together.
Mechanical contraction.
Right. Second, it seems to increase the rate of angiogenesis and granulation tissue formation. Third, it reduces the concentration of those tissue metalloproteinases, the MMPs that you find in chronic wounds.
Which inhibit healing.
They absolutely do. Fourth, it helps decrease the bacterial load just by continuously clearing the wound bed. And fifth, it decreases interstitial fluid, which, reduces edema and can improve microcirculation.
That makes a lot of sense. So let's talk technique. What are the 3 key steps to setting up an NPWT system?
It's a very standardized process, and the seal is everything. First, you cover the wound with an open cell sponge or a special gauze with the end of the suction tube buried inside it.
Okay.
Second, you seal the whole thing, the sponge and the skin around it, with a semi-permeable adhesive film. You have to get an airtight chamber.
No leaks.
No leaks. Then third, you apply suction from the machine, and that establishes your negative pressure environment.
Now let's talk settings. This is a common exam question.
Mm-hmm.
What's the pressure difference between an acute and a chronic wound? And is there a technique to boost granulation?
This differentiation is really important. For acute wounds, you generally go higher, around 120 millimeters of mercury. For chronic wounds, you use a much lower setting, more like 50 to 70.
And why the difference?
It just reflects the different physiology you're dealing with. And as for technique, we know that intermittent suction, say 5 minutes on, 2 minutes off, has been shown to increase the rate of granulation tissue formation more than continuous suction.
Good to know.
And don't forget, it's also used to improve the take of skin grafts. It's a very common application.
Okay, finally, the absolute must-knows, the non-negotiables. What are the 5 critical contraindications for NPWT?
You have to have these 5 down cold, and you need to understand the why behind them.
Let's hear them.
Number 1, malignancy in the wound. You risk seeding tumor cells. Don't do it.
That's a definite no.
Number 2, untreated osteomyelitis. The suction won't fix the underlying bone infection. 3, unexplored fistulae. You have no idea what you might be suctioning.
Could be catastrophic.
Absolutely. 4, if there's necrotic tissue or eschar present, you have to debride that first. The suction can't get through it.
So you're delaying proper treatment.
You're just wasting time. And number 5, don't use it on ischemic wounds. Applying suction could actually worsen the ischemia and increase the zone of necrosis.
That really deepens the understanding. It's not just a list, it's about actively avoiding harm. So what's the big takeaway for the clinician?
The bottom line is that success here is all about understanding the mechanism. You have to match the product to the wound's needs. Knowing a hydrogel donates water tells you what it's for, Knowing an alginate absorbs 20 times its weight tells you what it's for.
And with MPWT, knowing the contraindications is almost more important than knowing the benefits.
It is, because it ensures you're applying a very powerful but also potentially risky tool safely.
That is a perfect high-yield summary. Now let's leave our listener with one final thought. We talked about the different pressure settings for MPWT. 120 millimole Hg for acute wounds, but only 50 to 70 for chronic ones. Why?
Think about that. How does the underlying pathophysiology, the hyperinflammatory state of an acute wound versus that stalled senescent state of a chronic wound, how does that dictate these very different parameters? Consider that precise relationship between the pathology you're treating and the prescription you're writing for this powerful tool.